All right, so we're moving on. Basically, we're focusing on reproductive cancers here. We've talked about breast cancer. Now we're going to talk about ovarian cancer, and we'll move on and end up with prostate cancer. I've got some statistics here for you. I'll let you read those on your own. What I really want to point your attention to is this last one, talking about the rates that have been declining about 1 to 2% per year since the 1990s. And the different reasons for that. This is significant when you're talking about a cancer of this nature. It's less common, but it is an aggressive and deadly cancer. So that's a big win. So when we talk about the cause of ovarian cancer, it's unknown. There are things that we suspect as contributing factors, but we really don't know what causes it, what starts this process, other than obviously that cell dysregulation. I have included a picture here because I think it's good to review the physical aspects of this with the ovaries, the fallopian tubes, and the uterus. This cancer usually occurs here in these fimbriae, around the area of these fimbriae. So good to look back on that. Ovarian cancer is an epithelial tumor. If you remember back to when we talked about that general cancer overview and how we identify cancers, epithelial tissues are ones that line the organs and the cavities, and so this is a cancer that's occurring in the lining of those ovaries. It grows quickly. As I said, it's very aggressive. It's often bilateral. Usually it is bilateral because by the time we find the disease, it's usually metastasized to the other ovary, okay? So that bilateral presentation is usually a sign of that later stage disease. Metastasis frequently occurs before it's detected, so that's what we're saying. It's already spread to the other ovary. They are independent organs. It has a high rate of reoccurrence after treatment, and it is a leading cause of death from female reproductive cancers. Do. Age is a factor. Being over 40 is an increased risk factor, and the risk gets greater the older you get, and that's the same for most cancers. Family history increases the risk, as well as this Lynch syndrome, and we'll talk about that a little bit more in class. I have a personal experience with Lynch syndrome. It's an inherited disorder, so it doesn't just increase the risk of ovarian cancer, it increases the risk of developing some other types of cancer as well. You can see the BRCA1 and BRCA2 gene mutations. Those should be familiar from our work with breast cancer, but having these BRCA1 or 2 gene mutations also increases your risk for ovarian cancer. And then we have this excess estrogen exposure factors. So some of those things that we talked about before, that nulliparity, so not giving birth to any children, or for having your first pregnancy after 30. So you have that prolonged estrogen exposure during the height of those times where estrogen is being produced in the female body. Same thing with that early menarche and late menopause. It's that excess estrogen exposure. Infertility treatment as well. And then endometriosis. Endometriosis is highly estrogenic, so we have that increased exposure to estrogen because we have increased tissue production, and so that increases that estrogen production just by nature of endometriosis being tissue that's growing outside of the uterus and expanding. So when we talk about symptoms, you can see that there's some general GI symptoms here, this bloating or distension, pelvic or abdominal pain, indigestion or gas. That's what makes it very hard to distinguish, and we'll talk about this a little bit in the case study we do at the end, which is a personal experience of a friend of mine. But you know, these are things that we might look into as GI issues, not really focusing on the fact that it could be created by something wholly other like this ovarian cancer. The vaginal bleeding, again, if you're a younger age and you haven't reached menopause, you may have heavier or irregular bleeding, which you may take as a sign of menopause. It makes it very easy when we're in menopause to say, hey, we shouldn't have vaginal bleeding, you know, as we identified back in menopause, if that's something that needs to be checked out. But when you're of that younger age and you have this ovarian cancer, it's a little bit harder to discern. You may have GU symptoms like urgency and frequency, and that's just a byproduct of the cancer itself pressing against the bladder and irritating that. And then unexpected weight loss. This is a highly metabolic cancer. Cancer is highly metabolic, but this is a very aggressive, fast growing cancer. So even more so. I do have this. Ovarian cancer is difficult to diagnose until it has spread via the lymph system or by direct extension to the other organs. Again, spreading from one ovary to the other is metastasis. Okay, so and then you see all of the lymph that's involved in the abdominal cavity, and of course the multiple organs, the intestines, which are highly vascular. So it's very easy to understand how it can spread quickly once it's breached that epithelial tissue of the ovary itself. I've decided to entitle this section Diagnosis and Monitoring. I think it's important now to switch gears and really start distinguishing between true diagnostic and what we do to corroborate and to monitor. So when we talk about ovarian cancer, sort of specific lab work, we're talking about this cancer antigen, CA125. It's a tumor marker, so it's our body response, and we're monitoring those antigens, and of course, those antigens are going to be elevated. So when we have a patient with initial presentation, let's just say that they're having abdominal pain and some of those symptoms that we talked about previously, and they've had an ultrasound which shows a mass on their ovaries, and now we're going to do lab work. And now we kind of have this correlative picture. We have symptoms, we have lab work that's elevated and indicates and supports that that mass on that ovary is masses on the ovaries are most likely ovarian cancer. And as we said, imaging, ultrasound, transvaginal ultrasound, sometimes it's a little bit harder to see. So we may go with a CT or an MRI to try and get a better look and a more extensive look at that, a closer look, a more refined look. Also, CTs may be used to look for metastasis, right? So once we've confirmed that it is by biopsy that it is ovarian cancer, we may go back and have CTs where we're looking for any further metastasis in the body. As far as procedures, we have pelvic exam. That's just our annual exam where they insert their fingers in and they press down and they try and palpate the ovaries and the uterus for any masses. The biopsy obviously is our definitive procedure. That's going to give us the pathology, tell us what type of cancer we're dealing with, and say definitively that it is cancer. And then something like an exploratory laparotomy, which is where we can go in the abdomen and see what it looks like in the surrounding tissues. Let's talk about management. Management, obviously, we start with our primary prevention, which is risk reduction. The use of birth control and estrogen and progesterone for 5+ years, this actually reduces ovulation and associated hormones. So this is a strategy in some people. They believe that it is the ovulation that is also significant. Tubal ligation, so both ovaries are removed, both fallopian tubes, or even hysterectomy. Again, our ovaries are that primary estrogen producer, but the uterus does as well. So these are all options for risk reduction, especially for people who have some significant risk factors. Having given birth. So again, that can be a kind of swaying factor for some people. Breastfeeding for a year or more. This is not something that's for everybody, but it may be something that people may be more induced or likely to do if they feel that this is something that they could benefit from. As far as tertiary management, we can do staging. We talked about that exploratory laparotomy, so it's going to let us know if that ovarian cancer has perforated the uterus and if it's in the areas surrounding the ovaries. A total abdominal hysterectomy, and this is called a hysterectomy and a bilateral salpingo-oophorectomy, which means we're taking out the ovaries as well. That's where the oophorectomy comes from. This is the abbreviation for that, so we don't have to type that out every time. but we're removing the organ. So especially if it's contained, this is a very important surgery. We're also removing that estrogen exposure. Chemotherapy, we can have systemic chemotherapy. We can also have intraperitoneal. So again, this is the abdominal cavity. If we have any concerns that it has spread, that there's widespread metastasis in that abdominal cavity, intraperitoneal chemotherapy is absolutely an option, where we do a chemo wash inside of the abdomen. And then radiation. And we talked about internal beam and external beam radiation. And in this case, this brachytherapy, this internal radiation, this is what it can look like for an ovarian cancer. So you can see the little radioactive seeds here. They're put into the surrounding tissue around the tumor. And of course, over time, they lose their potency, but they're put in there to attack that cancer cell and to work in conjunction with chemotherapy to attack those cells and stop their aggressive reproduction. When we talk about pharmacological management, we're talking about chemotherapy, cisplatin with docetaxel. We can have it given IV, so that's usually every 3 to 4 weeks for 3 to 6 cycles. And again, if you remember, we talked about the importance of the patient getting the drugs that we prescribe at the dosages that we prescribe, at the frequencies we prescribe, so in this case every 3 to 4 weeks, for the duration that we prescribe, so 3 to 4 cycles. Can also go the intraperitoneal route, okay, so that can be given in addition to the IV chemotherapy. When we're talking about cisplatin and docetaxel, we're talking about some specific side effects. So in the case of these drugs, we're concerned about kidney damage. So we're going to be monitoring kidney function, right? We're concerned about neuropathy. That's a side effect of particularly the platinum drugs. We have concern for bone marrow suppression. It is chemotherapy, so that's going to be one of the concerns and things that we are going to monitor. And also ototoxicity. So we're going to be assessing the patient. This is an important education piece for the patients to know that they have the potential to lose their hearing. And so they're going to get regular checkups, and we're going to be assessing that frequently. And again, throughout this process, we're watching that CA-125. We're going to treat them, and we're going to see how it is impacting that CA-125, and hopefully that's going to come down. Intraperitoneal chemotherapy, you can see here, it's a cancer treatment that involves filling the abdominal cavity with chemotherapy drugs. I did put a link here for you to watch. It's only 4 minutes, but it's really fascinating. So hopefully you'll take the time to watch that. So once a patient has completed their chemotherapy regimen and they have shown through the CA-125 proteins, through imaging, that they have been partially or completely responsive to the chemotherapy, it's worked in the way that we wanted to, it's either shut down or significantly decreased that cancer, both in cancer antigen and size and extent of the cancer, maintenance therapy is what we consider next, okay? And we see, I gave you 2 names here. They actually work at they're different choices depending on the extent of the cancer. So one is for that later stage. One is for when you find it earlier, okay? This is Jula, is the one that my friend is currently on. And of course, with every medication, we're not trying to cure it. We're not trying to do further cure. What we're really trying to do is to maintain the advances that we've made through the chemotherapy and to kind of continue to keep it slowed down and at bay. The side effects that we would consider here, GI, again, abdominal pain, loss of appetite, nausea, vomiting, diarrhea, constipation, any one or coupling or group of those is possible. Neuro-wise, we're concerned about headaches, fatigue, and dizziness. Musculoskeletal, they may have muscle or back pain. And of course, we still have that concern for bone marrow suppression. As the nurse, our concern is in managing those side effects so the patient can continue to take this medication until they either develop some sort of toxicity or non-response to it. So we want it to allow them to be able to take it as long as they can. So we're watching and trying to manage these side effects. So again, that nephrotoxicity, we're going to encourage hydration. A lot of times patients do have hydration built into plans if there's a concern for nephrotoxicity. So they get saline infusion along with their treatment. But hydration is very important no matter what you're talking about with kidney health. So it's going to be important here in keeping that kidney flushed out and hydrated. And then, as we've done with every other kidney discussion, we're going to monitor the BUN and creatinine to make sure that that nephrotoxicity is not occurring or escalating. Bone marrow suppression, we're going to monitor that CBC. We're also going to look at symptoms, okay? We're not just looking at numbers. I had a patient who had a 6.5 and walked in like it was any other day, no problems. We still had to transfuse him, but he was really asymptomatic. You could not tell that he was walking around with a hemoglobin of 6.5. And on the other hand, I've had patients who have been at 7 and 8 and are symptomatic. So we're assessing a human being, not just numbers. So we're going to look at CBC and we're going to monitor symptoms of bone marrow suppression. We're going to watch for infection and monitor that ANC. Neuropathy. What do we have to offer the patient? Well, we're going to do assessment, right? Patient has to be educated and know how to protect themselves. This can be a serious side effect. It can affect daily ability to function and perform activities of daily living. So we're going to monitor it. We have cold therapy. So when we talked about breast cancer and hair loss, we referred to that cold capping. Well, this is the same idea. Patients wear mitts and booties when they're receiving treatment. The idea being that it's going to constrict those small capillaries near the surface of the skin and prevent the chemo from reaching those areas. And in that way, it's going to decrease that risk for neuropathy. Massage is another option. Hand and foot massages using essential oils. There was UPMC, there was a specific essential oil that we used. Decreased dose. This may be a reality when we're concerned about side effects of treatment. We don't want to destroy the patient's ability to function. So decreased dose, or even eventually taking medications out if the symptoms become too severe, because it's not just about functioning. There is a certain level of pain and tingling and numbness that goes along with neuropathy, so that could be a concern. As far as GI effects, we're going to manage constipation with stool softeners. We would manage diarrhea with antidiarrheals. Gas, pain, and bloating, we may look to diet to see if there are things that are more complicit in creating those side effects. And then, of course, for nausea, we have antiemetics. And we've just come such a long way with antiemetics. So we're going to use those liberally with our patients.